My financial interest is one, I'm a consultant for COA. As you know, COA is bringing a Rho kinase inhibitor to the market, which we are now evaluating with decimate stripping only. So many years ago, at previous editions of Cornea, Dr. Manis in Holland asked us to write a chapter on the preoperative considerations in decision-making in keratoplasty. And of course, the question is, what procedure is best suited for the patient? And for decades, we did one procedure, a full-thickness corneal transplant for all corneal afflictions and maladies. And now we are able to do layer-specific keratoplasty, which is an exciting time in the field of cornea. So with DALK, we are basically replacing the anterior 96% of the cornea, and with endothelial keratoplasty, the posterior 4% of the cornea. The best way to manage advanced keratoconus is not to get it in the first place. That's why the works of Dr. Rashid and Dr. Margaret are very, very important in trying to identify and treat patients early so that they would not require corneal transplantation. Now, the indications obviously for DALK and other anterior lamellar procedures are corneal ectasias, stromal dystrophies, and scars. This is known to all. The major advantage of DALK is to eliminate endothelial transplantation, because with the endothelium in these patients is healthy, and therefore why transplant it and increase the risk of allograft rejection. The other advantage that's not spoken of very frequently is that you have a closed system, and therefore the risk of a posterior unpleasant phenomenon, suprachoroidal effusion and hemorrhage, is almost eliminated. So this is an important advantage, not to mention the risk of wound dehiscence after a full thickness transplant. All of us who practice penetrating keratoplasty for decades would average 1 or 2 patients a year who would get up in the middle of the night, hit their head against the corner of their nightstand, and dehisce the wound, auto-express their lens, and frequently lose their eye. When I met Professor Muhammad Anwar many years ago, he tried to explain to me how DALK, how the big bubble procedure worked. And after an hour sitting with him, I had no clue what he was talking about, frankly. Fast forward 2 or 3 years, I decided to adopt this procedure. And what I thought was very helpful to me is to create an animation of how this works. And we did this with a graphic artist, an animator. And I want to share with you one important aspect of this that is frequently not discussed. People always ask, where are you injecting the air? Are you really injecting it at the pre-decimate level? So if you look at the insert in the upper right-hand corner here, we are trying to inject the air as posterior as possible, but the potential space, be it pre-decimase or be it pre-decimate layer, is not where the cannula ends. The cannula ends just anterior to that, and the pathway of least resistance for the air is posterior. So if you watch the insert carefully, you're injecting the air, and you are cleaving off either decimase membrane or the pre-decimate layer. Okay, once you're able to do that, the rest of the procedure is really simple and uncomplicated. And I'll show you one more important thing in the animation. So this is how the eye looks after the injection of the bubble. Again, please draw your attention to the insert in the upper right-hand corner. And as soon as we decompress the bubble, you have about 200 milliseconds to pull your sharp knife out before decimase membrane or the pre-decimate layer, also known as DUAs, moves anteriorly. Okay, so that's the whole concept. Usually when you show an animation, the audience may think you don't have a real case to show. So here's a patient with an intact swing segment who did very well for many years. He presented to our service with further advances in his keratoconus, asked if he had other options, and we recommended a big bubble deep anterior lamellar keratoplasty. The intact swing segment was removed, and you see me here injecting the air. And again, another pearl in the teaching here is that when you are injecting the air, you have to differentiate between the collateral damage, as they call it in the military, not a nice word, the difference between the collateral damage and the actual air bubble. So here is the emphysematous dissection of air. This is not the big bubble, but when the big bubble starts developing, you have no doubt in your mind that this is indeed the big bubble, right? All of you have seen this big bubble develop, and people think that it stops at the trephination mark. That's not always the case. Once that is done and you are confident that you have a big bubble, you know that that big bubble is either pre-decimate layer, PDL, or it is post-PDL. Anyway, you remove the anterior lamellae and you decompress the bubble. So this is the bubble that I put in the anterior chamber, and between 2005 and 2013, when Professor Dua published his major paper, I truly thought I was looking at Decimase layer here. And I would tell the resident or the fellow, look, we're looking at Decimase membrane, look how clear it is. I would be impressed by that. But then I would start touching it with the tip, the 19-gauge cannula of a balanced saline solution bottle, and the thing was very firm. And I know Decimase layer cannot be that firm. So, but still didn't know what was going on. We thought we were looking at Decimase membrane. All right. We removed Decimase membrane off the donor and brought it over the surgical field, sutured it into position using your technique of choice. And the procedure was terminated. We gave a lot of attention not to go full thickness with our needles because we did not want to perforate and create a possible double anterior chamber, a known complication with deep anterior lamellar keratoplasty. In about 2008, 2009, we started reviewing our cases with Professor Sarnicola from Italy to try to see what we can learn, what we can do better. This is at the same time as we started giving our course at the American Academy of Ophthalmology. And I'm going to share with you some just simple pearls. Everybody on this conference knows these, but they merit repeating. Please don't remove Decimase membrane off the donor until you are sure you're going to do a DALK, especially if the endothelium is healthy on the donor. So sometimes people are in the habit of just removing Decimase membrane before they start refining the recipient. Well, if you do that, then you do not have the option to do a full thickness transplant if you have a large perforation during the first parts of the DALK procedure. Once you are confident that you're going with the DALK, then that is the time to remove Decimase membrane off the donor. Okay. Now, if you are someone who likes to play loud music in the operating room, we're talking about hard rock here. This is not the time to play the music. You really, really want to have a quiet room as you're injecting the air. And what I want to show you here, and of course, all of you will recognize what has happened there. So I'm going to repeat this slowly. I basically started injecting air, and I'm going to slow this down. And then if you look inferotemporally, I started getting resistance, significant resistance to the air. I knew I had a big bubble, but I wanted to extend it all the way to the trephination mark, despite significant resistance. Well, there's a reason why it's not extending to the trephination mark. And obviously I popped into the anterior chamber, not a desirable development, right? So this is a coronary artery spasm inducing moment. So if you are injecting air and you get much resistance, stop. You already have most of the big bubble created and you don't need to do this anymore. And all you need to do is stop, and you can finish this with manual dissection, okay? All right, so stop if you get lots of resistance. Now, how to decompress the big bubble, and this was referred to historically as the brave slash. Well, I'm not a very brave person, and I don't need brave slashes in my life. So one thing I've learned is to, you'll see me here putting a bubble in the anterior chamber. This has been published by many. And watching how the sausaging of the bubble is around the big bubble. This is confirming the creation of a pre-Decimase or a pre-PDL big bubble. And then once you do that, you know for sure you have a big bubble. And what I like to say here is, if you are someone like me who makes that paracentesis to put the bubble in the anterior chamber after you create a big bubble, please make your incision more vertical than you would do most of your paracenteses, right? All of us are used to making paracenteses when we do cataract surgery, and we usually make them kind of at an angle flat with the iris. Well, if you do that and you have a long tunnel, you are likely to pop the big bubble internally, and you don't want to do that. So this paracentesis has to be more vertical, okay? Here I am putting a cohesive viscoelastic on the cornea when I make my brave slash. And the beauty of this, it slows down the egress of air from the big bubble. And when you slow it down, you have plenty of time to remove your knife from the eye. Instead of 200 milliseconds, you may have a full second, which is a comfortable situation, and prevent damage to the predestined layer and descemes membrane by the knife if it stays there too long. All right. When you're removing the posterior lamella, you need to make sure that it's completely separated from the predestined layer. If not, this is what can happen. Watch the next cut with my scissors. All right, aqueous came through. And the reason that happened is because I was not completely separated here from between the posterior stroma and the PDL. And when that happens, you perforate, not a reason to abort. You can just finish this procedure as a DALK. It requires a little bit more attention to detail. So be careful. Don't cut the posterior stroma unless it has been separated completely from the PDL, and I'll show ways of doing that. So here is another case, and you see me entering vertically to make my paracentesis. This is after the big bubble was created. I'm going to put a bubble in the anterior chamber, and instead I get all these fish eggs, not a problem. But here's the technique of making sure, and I'll show it again so that everybody can see, making sure that the separation of the posterior stroma is completely extending to the trephination mark. Once you do that, the risk of lacerating the PDL or descemes membrane is minimal. All right. So one more time, and it'll appear later in this talk. I'm going to show one more time. You are using here, there are many marginal dissectors on the market. This is simply a cyclodialysis spatula, and I'm making sure the posterior stroma is completely separated from the predestined layer all the way to the trephination mark. All right. Many instruments have been developed. These are the 10 instruments with a marginal dissector and the scissors with a longer posterior blade that protects the PDL while you're cutting the posterior stroma. Moria has created a disposable version of the Hanna Treefine that we all loved, that the Professor Hanna at Hotel Dieu developed in the late 80s. I have no financial interest in this, but I love this instrument. Something happened in September 2013. What happened? Well, Professor Dua's group from Nottingham described this layer in the posterior stroma, and for the last 8 years, it has created a lot of excitement, a lot of resonance, but on the other hand, a lot of negativity. And the negativity all arose from the fact that the Dr. Dua's fellows decided to call it the Dua layer. You're supposed to die before anything is named after you. Of course, we don't want Professor Dua to die. We love him. He's made huge contributions to the field. So let's go with predescemes layer, 5 to 20 microns thick, about 5 to 11 lamellae of collagen fibers, predominantly type 1 collagen with a high content of elastin-like fibers. This is important. We can talk about that separately. This layer is either acellular or paucicellular. You don't see keratocytes in this layer. Has a high bursting pressure. This is critical. So the bursting pressure of descemes membrane may be 25 to 30 millimeters of mercury, but the predescemes layer has a very high bursting pressure. And that's why we now know why it helps us with DALK. And we think it's continuous with the trabecular meshwork, a subject of a different discussion. So here is Dua's layer. Here's descemes membrane. And we used to think when we got a type 2 bubble, and I'll talk about that momentarily, it was an intradecimetic bubble, but it's not. It's between Descemet's membrane and Dua's layer. We also used to think that when we got the interdescemetic bubble, it was between the non-banded and the banded zone of Descemet's membrane. It is not, all right? There are several clinical applications to the pre-Descemet layer, but the most important one is to recognize what type of big bubble you got, and this will aid you in completing the procedure successfully. So big bubble type 1 is develops anterior to the pre-Descemet layer, also known as Dua's layer. Big bubble type 2 develops between Dua's layer and Descemet's membrane. So this is an important concept to understand, because once you recognize what kind of bubble you have, then you know how to move forward. And of course, some people have used the term big bubble type 3 when you have a combination of the type 1 and the type 2. Most of the time, you get the big bubble type 1, which is a safe way to proceed with DALK. If you get a big bubble type 2, it's a fragile situation. You have to be very careful in removing the posterior stroma to avoid perforation. Okay. Now, another feature of the development of the big bubble is with type 1, the bubble develops from center to periphery. All of us are familiar with that phenomenon. While in big bubble type 2, the bubble develops peripherally very, very quickly, all the way to Schwabe's line. And that is a recognizable phenomenon when it happens. I had to mine hundreds of videos before I found this in the late 2000s, but I'm happy to share it with you. So this is a big bubble type 2. Notice how it goes all the way peripherally. Notice that there is very, very little collateral damage, if you will, which is the emphysematous wave. Let's show it again. I'm injecting air. The air is going immediately to the space between Dua's layer and Descemet's membrane. And the importance of this when you get it is you have to be very gingerly, very careful in removing the posterior stroma. And look what happens here. These are rounded scissors. They are not sharp. I'm removing the posterior stroma. I did not recognize that the structure here is actually Descemet's membrane as opposed to the pre-Descemet layer. As soon as I touch it, I pop into the anterior chamber, okay? So this is important. I'll show it again. Again, this is at a time where we did not know about the Dua's layer. So we didn't know the difference between this structure and anyone in big bubble type 1. And as you see here, I barely touch it and I have a perforation. Not a problem, not a reason to abort, but it's good to understand. So some surgeons have decided when they know they got a big bubble type 2, not to remove the posterior stroma. They feel it's safe. They leave a layer behind. They know the visual acuity will not be as sharp as if you remove it, but they think it's adequate and much safer to be able to complete the procedure as a big bubble technique. So if you have $300,000 to spend on an intraoperative microscope mounted OCT, instead of sending your kids to college, then this is a wonderful device to have. It's very helpful in surgery. As you can see here, you can tell exactly where the big bubble is. You can tell the extent of the big bubble, and it decreases the chances of perforation if you are trying to expand the bubble with a cannula. Now, I'd like to show you something here. This is a patient, as soon as I started injecting, I saw bubbles, all in the anterior chamber. So I knew I had a perforation in the pre-Descemet layer and Descemet's membrane. So you may say, okay, time to convert to a penetrating keroplasty. Well, the answer is no, it is not time to convert to penetrating keroplasty. You have a single perforation and there's no reason to convert. Lamise was talking about this earlier, and she asked very diplomatically, I'd like to know what the incidence of Sadeer's perforations are. And Lamise, they're not low, they're high. So if you ask me how frequently, easily 20%, okay, guilty. But the vast majority of those can be saved and maintained as a DALK, not converted to a PK. So what you see me doing here is I'm going to, and I'm preparing you for what you're going to see, I'm basically going to inject balanced saline solution and thicken the posterior stroma, and then do a layer by layer dissection, similar to what Professor Barraquer described many, many years ago. And watch, let me go back a little bit here to show after removing the last layer, look how pristine the posterior stroma is. This is neither Decime's membrane nor the pre-Decime layer. It just has about 80 microns of remaining stroma, and it's pretty clear. So this patient will have good vision at the end in the range of 20/30 or so. Okay, a layer by layer dissection, and you can bring a case like this with a scar which has a higher incidence of perforation because of the adhesion of the posterior stroma to the pre-Decime layer. You can bring it to a very successful conclusion with a good visual result. Well, what about the double anterior chamber, the nemesis of DALK surgeons? You think you did a beautiful procedure, and over the past 15 years, I would get calls from colleagues who will say, Sadeer, trust me, I did a beautiful DALK. There was no perforation. Why did this happen to me? Similar to colleagues who call you and say, it was a routine phaco. I don't know why the cornea decompensated. Now, notably, most cataract surgeons do not do endothelial cell evaluation on their patients before cataract surgery. So here you have a double anterior chamber. You can see that the donor is very edematous. This is post-DALK. And as soon as you remove the air or the viscoelastic from the interface and the endothelial pump starts pumping fluid, before the patient leaves your office, again, before the patient leaves your office, you can convert this, you can reduce this like you would reduce a hernia, this double anterior chamber, and the endothelium starts decompressing and defervescing the donor stroma. Okay, for the people, for the attendees of this lecture, if you want to take a picture of, this is my rebubbling kit. I use it for DALK. I use it for DMAC, for DSEC. This is my standard rebubbling kit. I do all these rebubblings in an upright position in the office. I know the Mies in Europe, you frown on that. I think you like to take them back to the operating room. That's a different story for a different time. But this is how we. Now, one thing that is not discussed, everybody talks about putting a bubble in the anterior chamber to reduce the double anterior chamber. But what if you had a layer of viscoelastic in the interface that's going to prevent you? So by the way, no dispersives in DALK, no dispersives in DALK, should use a cohesive viscoelastic. But if you have something in the interface, a bubble in the anterior chamber is not going to be able to blast it out of there. So one thing I do on every, not that I have too many double anterior chambers, I put the bubble in the anterior chamber, and then I go to the graft host interface and part it a little bit, and then squeegee any fluid or viscoelastic that's in the interface, again, in the same sitting at the slit lamp to bring the pre-Decime layer and appose it to the donor. Once you do that, the cornea starts defervescing again before the patient leaves your office. All right, I have a few more minutes here, so I'm going to finish with showing you an interesting case. This is a patient with a herpetic scar, and you may say, okay, what's the big deal? Well, the big deal are there are adhesions frequently posteriorly, and I'm not going to go through the whole video, but I'm going to show something which I think is important. So basically here, I'm using the Hanna tree fine. I'm going to tree fine to about 300 microns. I've been doing this for a long time. Reasonably proud of myself, but I know I could get problems. So here is a diamond knife to go a little bit deeper based on local pachymetry, because as you know, the deeper you go, the more likely you are to get a big bubble type 1. And I'm going in with a Fogla probe, but I noticed when I put the probe into the eye, it was wiggling a little bit. Wiggling is not good. It means it's in the anterior chamber. It's not in the posterior stroma, as you see there. So I said to myself, okay, let me see what happens if I go again. Anterior chamber again, not good. So I have a perforation. I'm going to go somewhere else. Take my 27 gauge needle, start a small track, then go in with my probe, and now no wiggling. So I'm happy. Nice big bubble, but there's a small air bubble that went into the anterior chamber through the previous perforation. Look again, big bubble, but there's an air in the anterior chamber. So I'm very, very happy that I got a big bubble, but on the other hand, I know there's a perforation. Now, the important part of this video is to say to you, you have to be mindful of this. So let's move forward here. And I put some air in the anterior chamber. And now I'm going to put my viscoelastic, again, a cohesive, between the stroma, the posterior stroma that is, and the predestinate layer. And I'm going to start excising the posterior stroma. But I know there's a perforation somewhere here. So I have to be careful. Here I go with my marginal dissector. I know the big bubble did not extend all the way to the trephination. So I'm using the marginal dissector to carefully do a manual dissection to separate the posterior stroma from the predestinate layer. At that point, I can safely remove the posterior stroma and complete the procedure. I am very fond of using an instrument, in this case, a marginal dissector, to make sure the posterior stroma is completely separated from the predestinate layer before you put your scissors there to remove it. Okay, once you do that safely, you can remove the posterior stroma. And once that is done, obviously, you go to your donor, you strip Descemet's membrane, and usually the PDL of the donor stays on, not a big thing. Here I am making sure the endothelium is devitalized, and I remove it with Descemet's membrane. And then we're going to simply transfer it onto the recipient and suture it using the technique of your choice. All right? So in conclusion, I think anytime you have a healthy endothelium with a corneal scar or an ectasia or a dystrophy, it is reasonable to consider DALK. You have a secure wound with DALK. The incidence of allograft rejection is much lower. But like a game of chess, always be ready for the next move that the patient's eye may present you with. It's nice to be ready several moves in advance. Now we have about a decade and a half experience, at least in my practice. And of course, Professor Anwar described this almost 2 decades ago. So we have a lot of experience with DALK. Still, the adoption rate is very low for many reasons that are beyond the parameters of this talk. And some people also don't have access to tissue in parts of the world. That's why I'm very impressed by the work that Dr. Susan Jacob is doing to try to avoid getting to this stage of keratoconus, and by the works of Dr. Baidoun to stabilize the cornea so that all you need is a fortification with a layer of Bowman's before the patient's vision deteriorates to the point that they need a graft. I think it's very good to be mindful of the predestinate layer, also known as DUAs, because it is critical to the success of DALK. I really appreciate you asking me, Dr. Anas, to be part of this symposium, and to Dr. Merjan for organizing it.